Hi everyone, and welcome to Bronchology Chat by AB El Reyes. On today's episode, we will cover a topic that discussed during the ABIP third conference that was virtual by Dr. Najib Rahman that covered the year review in pleural disease. I hope you enjoy it.
Hello everyone, my name is Najib Rahman, Professor of Respiratory Medicine from the Oxford Pleural Unit. It's a great pleasure to be here, and I'd like to thank the AABIP for asking me to give this talk, which is on the pleural year in review for this virtual conference. These are my financial disclosures. I've revealed all of them here. Several of them are potentially important for the talks that I will give concerning the MIS2 regime and indwelling pleural catheters. I must also state that a number of studies that I'm reviewing today, I'm an author on them. Unfortunately, that's not preventable, but I've tried to be as fair and as balanced as possible in considering what the importance and the meaning of the studies are. So this is an overview of my talk. There's been a lot of great studies produced in pleural this year. We're going to cover drainage strategy, diagnostic pathway, something on physiology and symptoms, large number of studies on malignant effusion management, and then finish up with pleural infection and then pneumothorax. So firstly, drainage strategy. The first area of interest is two studies that have looked directly at manometry, and both of these are interesting in their own right. One by Rob Lentz and the IPC group, published in Lancet Respiratory Medicine earlier this year, and then one by the Glasgow group, Kevin Blythe's group, called Pre-Edit. And I'll just handle each of those one at a time as we go. So let's just put all of this in context. What do we know about manometry, or what did we know before these studies? We have large-scale case series data that suggests manometry does not prevent complications, does not predict re-expansion pulmonary edema. There are some early data suggesting it may predict pleurodesis outcome in those in whom expansible lung has not been diagnosed, but as I've stated, these were case series data only. And in this context comes Rob Lentz's study, as I've said, published in Lancet Respiratory Medicine. What did the investigators do? This was a prospective single-blind randomized trial, so patients were blind as to what form of drainage they had, and they randomized patients to either symptom control or manometry control in large volume pleural aspiration. The novelty of this study was using a very key clinical outcome measure that's meaningful to patients, i.e. how much pain did the patient have during and just after the thoracentesis. And this is important because no study has addressed whether there's a patient-based or patient-facing advantage to having manometry conducted. Given that we know it does not help in preventing complications, this is an important outcome. And as you might expect for a well-designed trial, there were very protocolized stopping criteria, and the stopping criteria were necessarily different in the manometry arm and the symptom control arm, although in my view conservative in both, i.e. Very fairly done between both the two treatment arms. This is the consort diagram. They received 243 patients in total, of whom about half were randomized. The non-eligibility was for a number of very reasonable causes. And once you've got to the 128 randomized, you can see that the vast majority, over 95%, went on to complete their primary outcome measure. Why is this important? Because it implies there's no pre-randomization bias, and it also suggests that the data completion was extremely good. And this is what they found. The mean difference in their pain score was only 2.4 millimeters. Now, many of you will know that the minimum clinical significant difference for a pain VAS, at least in pleural disease, is in the region of 14 millimeters. The 95% confidence interval crosses zero, and therefore, as expected, this was a non-significant study. The only outcome, I haven't listed all the secondaries, but the only outcome that was of note was the asymptomatic pneumothorax ex vacuo rate. So that's how often was a chest x-ray performed and demonstrated a pneumothorax post-procedure, albeit not requiring any form of intervention or management. And this was significantly higher in the control group. So 10% of the control group had a pneumothorax ex vacuo versus only, in fact, no patients in the manometry group, and unsurprisingly that was statistically significant. This is their primary outcome presented visually, which I think gives us some interesting signals. So just to explain the graph, along the bottom here is the volume of millimeters aspirated during the thoracentesis, and up here is the 100 millimeter VAS score, with 0 being no pain and up at 100 here being maximum pain. And you can see that the 95% confidence intervals of the two, with orange being manometry, cross all the way from small volume all the way up to larger volume. So regardless of how much fluid is taken, there's no advantage to manometry. In fact, I think the interesting signal here is that as time progresses, and potentially if the thoracentesis had continued to 3 or 4 litres, it would appear that manometry is associated with increasing pain. And I wonder whether that's because in the symptom-guided group, the clinicians are much more conservative and careful to stop in response to pain, whereas in the manometry-guided group, with a little bit of pain, one might persuade the patient to have more thoracentesis or more volume removed, because the pleural manometry does not suggest the development of a negative pressure pleural space. Nonetheless, no significant difference between the two arms. So why is this an important study? Well, it's the first ever randomized trial using manometry with a decent power calculation and a very key patient-facing clinical outcome. I think we knew before this study that manometry could not be used to increase safety in any way. So was it therefore useful to help our patients? And the answer is a very firm no. It is not justified to use routine manometry, in my view, after this study. And although some authors have made quite a lot of the reduction in asymptomatic pneumothorax, this is a condition that can be diagnosed immediately afterwards using a chest x-ray, and in most patients will have no implications whatsoever. I guess if the patient was due to take a flight in the next week or so, there may be an argument for trying to prevent pneumothorax ex vacuo, but I think that's the only circumstance under which manometry has any advantage. Beyond that, I think manometry for the routine use in thoracentesis has basically died with this study. Okay, the second study in manometry is this study by the Glasgow group, so this was called the pre-edit study. Now, to be clear, this is a small study. It's a feasibility study only, and they used a novel method of manometry, which I'll come on to in a second, in order to predict non-expansile lung, or NEL, and they measured pleural elastance using a novel catheter that was inline and live. So there was a couple of novel areas here, one being the measurement of pleural elastance and the second being the novel catheter. On the basis of the pleural elastance measurement during the thoracentesis, they would then randomize to either standard care, which is pleurodesis, or EDIT, which is elastance-directed pleural catheter or pleurodesis. And I think that's the novel factor in this particular study. Previous studies have looked at manometry in terms of predicting pain or complications or a problem directly in the thoracentesis. Here, the manometry is being used in a theragnostic sort of way. So can we diagnose what the best treatment pathway is for the patient? And I think that's a very novel and intelligent way of moving this field forward. This was their scheme. There's a lot of extra data here, but essentially they took symptomatic malignant effusions, they did ultrasound and MRIs, which was part of another study, and then they divided them according to whether they had a high pleural elastance, in which case they went on to IPC, or a low pleural elastance, in which case they went on to drain and talc slurry pleurodesis. And this was pre-edit management. The other side of the coin simply had normal thoracentesis. And this is the novel catheter created by Rocket Medical, which gives an inline measurement into an electronic outcome box, which allows live measurement of the pleural elastance. Now, as I've stated, this was a feasibility study, and therefore one isn't expecting large results here. 13 of their 15 patients had complete PEL data. The 2 patients that didn't complete it were due to a software issue which was solved, and the subsequent 13 all had good data. And they had a high accuracy of PEL sensitivity for the prediction of entrapped lung, so 100% sensitivity and 67% specificity. As you would expect, the confidence intervals are very wide because it's a small study. So what do we conclude from this? Well, this won't change practice, but it is clear that novel measurement of elastance using the catheter is feasible. Patients were willing to be randomized, and a phase 3 study, and that's called EDIT, where manometry is allowing patients to predict which pathway they're going to be in, is now underway. And I think that's a potentially exciting new move forward for the pleural manometry world. Okay, let's go on to drainage strategy. So 2 really important papers published this year. The first by Rob Lentz and his team again, the Gravitas study, senior author Fabian Maldonado, and then the Senitko study, which was published in JOBIP a bit earlier this year. What do we know? What's the context? Well, we all know thoracentesis is very common, but the optimal method, and I've put that in inverted commas, is unclear. What do I mean by that? I mean the best way of deriving the most patient benefit but causing the least harm. And our options in terms of what we could change are, do we use manual aspiration? By that I mean a catheter with a syringe that you pull and push during the thoracentesis. Do we simply connect the thoracentesis catheter to a bag and allow gravity to do the work, gravity suction, or do we use active suction, which could be via wall suction or via a negative pressure bottle? And all of these methods are very variably used. So the purpose of Gravitas was to directly compare patients undergoing gravity suction versus hand suction, and this was published in Chest a bit earlier this year. So once again, a well-designed study, randomized 1-to-1, 200 patients initially assessed, a few dropped out largely because they were ineligible, and then of the 142 randomized, there was a slight imbalance in the randomization, but again, only 2 patients lacking outcome data, so really good data completion and no worries about pre-randomization bias. This is their primary outcome slide. They once again use the VAS score for pain, a validated score in pleural disease now, and they demonstrated that even though patients in the active aspiration arm had higher pain to start with, there was no significant difference in pain all the way up to 48 hours post-procedure. So really no winner comparing the two, and this is the same data demonstrated showing you the spread of data. So there is a very large width of data, some patients having almost no pain, other patients in severe pain during the aspiration. If we look at whether it had an impact on other factors to do with the procedure, so does gravity or active aspiration affect the volume of fluid drained? It's identical, the amount of fluid drained, and again they had protocolized management of how much fluid to remove from the chest. The procedure duration was significantly different, and there was a small saving. This is time in seconds, so there was a few 100-second saving using gravity versus active aspiration in the region of 5 minutes or so. So what do we conclude from this? Well, again, this is the first direct randomized study to compare drainage methods in thoracentesis, a really important study that I think will affect how all of us practice. What they found was no clinically significant difference in outcomes, which is good, a slightly longer procedure time with gravity, and therefore it's very reasonable now to use either gravity or manual aspiration. I guess some authorities would suggest that because manual aspiration saves time, one should use that in preference. I personally don't feel that way, and I feel that gravity aspiration is the more physiological. It allows me to get on with some paperwork while it's occurring, so that's my preference. Let's move on to the second study. That's the Senitko study published in JOBIP last year. Now, what's the difference here? This was a vacuum system versus manual drainage, so the aspiration using a syringe versus active vacuum, not gravity. And in this study, again randomized, they randomized 1-to-1 between the two different drainage procedures. Now, their primary outcome was somewhat different. It was a combination of complications and need to terminate the procedure and a number of different secondary outcome scores. This is their primary outcome measure, and then some of the secondary outcomes on the right-hand side here. So you can see here that the manual aspiration group had 0 complications and a very small frequency of early termination, whereas there was a significant number, just under 10% of complications using vacuum, and a much higher level of early termination as well. Now this was their combined primary outcome and is clearly in favour of manual aspiration against vacuum. Not only that, but the patients in the vacuum group had greater pain during drainage, although this was delivered with a shorter drainage time. So what does that tell us? Well, I think the Senitko study tells us there are significant potential harms with the vacuum aspiration technique. Now, I think there are some issues with this study. This study did not have a prospective sample size calculation, and this was, the authors confess, was a convenient sample. It's a 100-patient study, so it's not tiny, but nonetheless, the small sample size does lead us to imprecision in estimating the true harms of vacuum, but they're certainly higher than manual aspiration. And in my view, although there are some issues with this study, I think vacuum drainage should probably now be avoided on the basis of this study alone. Okay, let's move on to my second area, and that's of the diagnostic pathway. What's our context here? Well, this is the BTS Pleural Guideline 2010. This still stands as the only evidence-based suggestion of how to investigate the undiagnosed effusion. And I've just highlighted two boxes on a busy slide. That is that the first investigation should be a pleural aspiration, and only if the pleural aspiration hasn't given us a clear diagnosis should we move on to the more invasive diagnostic strategies such as pleural biopsy at thoracoscopy or image guidance. And this is a mantra that all of us have believed in since our training. I think there are some recent data that might question whether this should be applied in all cases, and hence maybe it's time for us to rethink that diagnostic pathway. So this was the first bit of data. This was from David Arnold and Nick Maskell's group in Bristol. In this, they looked at 921 patients. It's by far the largest study to have done this. And what they looked at was the cytology yield of initial aspiration according to final diagnosis. And no one had ever done this before. And what they found was really quite stark, that depending on the final malignant diagnosis, the cytology yield varies from over 90% to less than 10%. I think we all knew that mesothelioma has a very low diagnostic yield on cytology unless you work in certain centres such as Perth, where they seem to have an extremely high diagnostic yield with cytology. But it's interesting to reflect that patients with, for example, breast cancer and lung adenocarcinoma, the yield is around 70–80%, whereas non-adenocarcinoma lung, it's less than 20%. So it's interesting to reflect that maybe, given that we do have some pretest probability of what the underlying diagnosis is going to be, maybe in some cases we should be doing a thoracentesis, and in other cases we maybe shouldn't for diagnostic purposes. So that's the first step along this journey. But the second step, I think, is this paper, in which they went beyond just the sensitivity. And just to explain, in this paper they wanted to push forward not just to the sensitivity of cytological diagnosis, but to the usefulness of the cytological diagnosis, i.e., was the cytology sufficient to allow oncological treatment? So this was a retrospective analysis of another prospective study, and which was on mesothelioma and malignant effusion. And in it, they analysed these parameters: what was the final diagnosis, and then a number of patient parameters, the cytology, asbestos exposure, and what the CT reported, malignant or non-malignant. And then they looked for independent predictors of negative cytology, like the previous study, but also of what they termed incomplete cytology, meaning that the predictive markers, the oncological treatment paradigm helpers such as EGFR and so on, were they available from the cytology? So this is moving slightly into the functional ability of cytology to predict the patient's pathway. Now, they had 283 patients diagnosed with malignant effusion, and the fluid cytology was negative overall in quite a large number, 63%. Very interestingly, that they found that the negative cytology was dependent on two things. If the patient was asbestos exposed, there was a higher likelihood of negative cytology. I think we can all understand the reason for that, which is that that increases the likelihood of mesothelioma, which has a low diagnostic yield at cytology. So that's very explainable. However, a malignant-looking CT on those classic Leung criteria was also associated with a negative cytology, and that's somewhat interesting. I think probably it's operating in the same manner as asbestos exposure, in that it's more likely that you will show malignant pleural disease on a CT, perhaps, if you have mesothelioma. So this may well be the same mechanism. If you looked at patients who had both asbestos exposure and a positive CT, meaning a malignant-looking CT, then the cytology sensitivity was really very poor indeed, only 19%. And most importantly for us, perhaps, the negative predictive value was extremely poor. And that means that if you have a patient who has both asbestos exposure and a positive CT, then neither a positive nor a negative is particularly helpful. They then looked at the odds ratio for incomplete cytology, as I've explained before, and it was very variable according to cancer type again. So if we put these two studies together, and there are other groups, including my own, that have started to look at this, it would seem that cytology alone is rarely a helpful thing to do in the modern era. And so therefore perhaps it's time to rethink the old pathway. Perhaps we should move more to a direct biopsy approach, and perhaps we should move to some form of risk score before we do a thoracentesis to say, look, how likely is it that this thoracentesis for diagnostic purposes is going to be helpful? I'm not suggesting that thoracentesis should not be used. It is, of course, a therapeutic procedure as well. But if we're thinking purely in the diagnostic regime, maybe we should think carefully and perhaps even skip the diagnostic thoracentesis step. Okay, let's move on to physiology and symptoms. So a bit of background here. This is a thoracic ultrasound, you're all familiar with this, showing a very large effusion and a diaphragm which is the wrong shape, so it's inverted, it's flattened, and it's moving very poorly with respiration in the presence of a large effusion. And if we remove 500 mils, then this happens, and the diaphragm pops up to a normal shape. There's still a large amount of pleural fluid. The lower lobe is still atelectatic, but the patient feels much, much better. And so for a long period, we've thought that the diaphragm is important in predicting symptom and symptom relief, but that's never been proven. We do know something about symptom relief in thoracentesis, so this is a study from my own group from about 5 years ago, where we used the VAS 100mm measurement in breathlessness, and we looked at how often thoracentesis and therapeutic procedures resulted in a clinically significant improvement, and the answer was about 80% of cases, and this was directly related to the amount of fluid drained. So in this context comes this excellent study. This is from Gary Lee's group, the PLEASE study, published in the ERJ this year. So this is a large prospective study, 145 patients, it's observational, and what they did was took patients who were having a therapeutic thoracentesis and assessed them pre and post drainage, and then 24 to 36 hours post drainage, in a very systematic way. So they measured breathlessness, quality of life, radiology parameters, and spirometry. And I think without question this is the best physiology symptom association study that we have in the literature to date. Now this is their main outcome slide. I won't go through every line one by one, but just to give you some themes. So the VAS, once again, was significantly improved. I should explain that in Australia they do everything upside down. So the VAS scores that we have used, 0 is best, 100 is bad. In Australia it's the other way around, so 100 is good and 0 is bad. And these patients are pretty symptomatic at about 44 before you do a thoracentesis, and they are significantly improved by the thoracentesis. So the MCID, the minimum clinical difference, in this outcome measure is 19 millimeters, and this was statistically very significant. So patients are feeling better on the traditional validated outcome measure. That's all very good. The interesting thing about this study is that the VAS associates very much with a number of different measurements of patient symptomatology, which is also extremely good to see. This translated to an increase in their 6-minute walk distance as well, and interestingly in a reduction in heart rate and a reduction in respiratory rate, as we would predict. So the physiology is changing. But as we have predicted for some time, the saturations are not changed at all, probably because of shunting within the lung, and the spirometry is statistically different, but I think clinically none of us would be too impressed by 40 or 50 or 100 mils of improvement. So I think this study has really given us the best evidence we have of what happens physiologically during a large volume thoracentesis. Now, they also divided patients into those who responded. Their MCID was 14 millimeters, and those who did not respond. And once again, as in our study, they found in the region of 20 to 30% do not respond to a thoracentesis that is of large volume. The great thing about this study is they went on to look at what the predictors of that might be. Now, I'll come back to that in a second. They assessed the hemidiaphragm and found that it moved from being abnormal in terms of shape. In 50% pre-drainage, 94% was back to normal, and then the movement went from 48% to 73%. So we've got some very clear data that changing the diaphragm function can help our patients. The predictors of dyspnea relief, this was by multivariate analysis. This showed a number of things. Firstly, the abnormal diaphragm movement predicts a good response, and that's what we've suspected clinically for some time. Being breathless before the procedure predicts if you will get relief from breathlessness. Now, that makes statistical sense because the higher the outcome before you start, the more likely you are to change it. And then there were 3 outcomes which were associated with response to dyspnea, which I must confess I don't truly understand. So having a benign etiology, having a higher pleural pH and having a higher serum albumin. Now, I can understand why a benign etiology might respond better to thoracentesis. The malignant patients perhaps have other reasons for breathlessness, lymphangitis, pulmonary embolus. But the higher pleural pH and serum albumin, to me, doesn't make any scientific or mechanistic sense. It is possible that these two are simply co-correlated with benign etiology. So as I've said, a very good in-depth symptom assessment confirms our suspicions about the diaphragm. We once again found that around 20-30% of patients are non-responders, but the mechanism of that is unclear, and that's clearly an area that we as clinicians need to investigate. And they've just started to open this idea of predictors of dyspnea relief. I would argue it would be very valuable to know which patients are going to respond to your thoracentesis before you do it. Okay, let's go on to malignant effusion management. 4 important areas to cover. The first being the TAP study, then a systematic review of IPC versus pleurodesis, a Cochrane meta-analysis of malignant effusion management, and then a number of MPE and IPC guidelines. So this is the TAP study. Most of you will be familiar with this. This is a study that I was part of, but driven by Nick Maskell's group in Bristol, randomizing patients to thoracoscopic poudrage versus talc slurry pleurodesis. Since the Dresler study many years ago, there's been a debate of whether poudrage is better than slurry, and increasing evidence that there's no particular difference between the two. This was really the Dresler study done properly. 330 patients randomized, excellent outcome data available, which is one of the major problems of the Dresler study, and showed exactly the same as the Dresler study. So really no difference between poudrage and slurry, with the Kaplan-Meier crossing on 2 occasions, and as you would predict, a negative log rank test. So we now have multiple RCTs, not just this one, showing no benefit of poudrage over slurry, and in my view there is no justification for conducting a poudrage in favour of slurry pleurodesis. If you're doing a thoracoscopy, you're taking biopsies, and there is an opportunity to do a poudrage, there's no problem doing that, but one cannot take a patient with an identified malignant effusion and push them towards poudrage, pretending that it increases efficacy, because it does not. Now that moves us towards this excellent systematic review done by Naren Iyer and colleagues, looking at pleurodesis for malignant effusion versus indwelling pleural catheters. They looked at 5 randomized and 5 non-randomized studies, which were of good quality and good design, and this includes the normal ones that we talk about. So that includes the Time 2 study and also the Ample 1 study, and then a number of observational studies as well. Let me just highlight some particular findings. Firstly, there was no change in mortality. None of us would expect that between IPC on the left or pleurodesis on the right-hand side. The number of repeat pleural procedures, as you would expect, is very much favoured by using an IPC. But I must point out that this is a physician-centric outcome. So the question here is not how many pleural procedures does the patient have, it is how many pleural procedures does the physician need to do. So I argue nowadays that this is the wrong outcome, because the patients having an IPC, in fact, conduct their own pleural procedure 3 or 4 times per week. So this is a real outcome, but it is from the physician perspective. And the IPC is associated, it would appear, with modestly more pleural infection and definitely more cellulitis, obviously expected because a piece of plastic is retained in the chest. This feathers in well with this excellent meta-analysis, which is an update from previously done by Millie Clive. She's now senior author, and now Alex Dipper from Nick Maskell's group. So their methodology here is very good. They collated all of the data in the literature looking at optimal management for malignant effusion, and just a shortcut, what they end up doing is ranking each method of pleurodesis or pleural fluid management for malignant pleural effusion. This is only from randomized trials, so this is high quality data. Now I apologize that this didn't reprint very well, but I'll only highlight one thing. Over here are the highest ranking interventions, and over here are the lowest ranking interventions. And just to be clear, the talc related interventions are in blue and the IPC related interventions in red, including IPC plus not daily drainage, IPC plus daily drainage, and IPC via the, talc via the IPC. So there's a clear preference here for talc as an inpatient in the meta-analysis. So let's ask that question. Is with IPC plus and with daily drainage, should we now be abandoning talc slurry as an inpatient procedure in favour of IPC plus talc plus daily drainage? Well, we can answer that question directly from the literature in an indirect manner. This is the TAP result. This is the, sorry about the slides, this is the TAP result, this is the ample result. What I've done is compare the pleurodesis success rate at the same time point, which is 90 days. In ample 2, which was daily drainage, as you'll remember, in the intervention arm, at 90 days, the pleurodesis success rate was just low of 40%. Same time frame in TAPS, 78%, so a huge difference between the two. Okay, so daily drainage on its own, perhaps not good as good as inpatient talc. What about outpatient talc? Well, this is IPC Plus, the New England paper, versus TAPS. Again, if we take the same time point, which in this case was around 9 weeks, because that's as far as this study went, 9 weeks, 55% roughly speaking. At 9 weeks, it's comfortably 80% with inpatient talc. So in my view, the optimal talc method, or pleurodesis method, is clearly inpatient talc, and we can't sell them as equivalent currently. I think we need direct comparative studies of talc to IPC to talc plus daily drainage and IPC, and some authors are planning these soon. I must mention these three very briefly. So there was the excellent ATS guideline led by Dave Feller-Cotman, and then Russ Miller and Chris Gilbert have also conducted Delphi or uniform consensus statements on the management of indwelling pleural catheters. They're really excellent guidelines which give you a real sense of some of those difficult questions. How do you treat infection? What do you do on blockage? A lot of it has revealed that we don't have a lot of data in this area. We need better data, but at least they're really useful, pragmatic ways of managing your patients. Let's move forward to pleural infection. I'll only highlight one study, which unfortunately is my own. So this is the rapid criteria for prediction of outcome in pleural infection. Nick Maskell and I published this 5 years ago, and John Corcoran has just published in the ERJ the prospective validation of the rapid criteria called the pilot study, which included many centres across the world. We recruited 550 patients, and those baseline parameters in the rapid criteria very beautifully predict outcome at 3 months and 12 months. So we now have a very robust and solid way of predicting who is going to die in pleural infection. Now, have we proven that it's useful? Not yet, because we now need to do a study where we triage patients according to rapid criteria to varying levels of aggression of management, but nonetheless I think this is an exciting and useful clinical tool that will probably become standard management. The second paper I will highlight is the Kheir randomized trial. So this was a very brave study in which they randomized patients to either the MIS2 regime or medical thoracoscopy, allocated 1-to-1. The primary outcome was length of stay, but I should be clear, it was length of stay post-intervention, so not length of stay post-randomization, and that's important when we look at the outcome. It was a small study, 32 patients, but this is a difficult area to investigate, and they demonstrated that medical thoracoscopy, this is the wrong way around, medical thoracoscopy had a 2-day stay, and IPFT had a 4-day stay, so this favoured medical thoracoscopy with a shorter total length of stay, with no differences in other outcomes. Now, to be clear, in a 32 patient study, if there's no differences in outcomes, then this probably means it's a false negative, or one cannot be sure it isn't a false negative. So does this mean that thoracoscopy is better than MIS2? Well, unfortunately, I think this study is far too underpowered to say that. And the primary outcome, because it's from the time of intervention, not the time of randomization, this biases towards medical thoracoscopy. It does show it's feasible to recruit, and we clearly now need a direct head-to-head, large-scale prospective study randomized to look at these two interventions. Okay, in my last 5 minutes I'll talk about pneumothorax, and potentially 2 of the biggest papers this year have been published in pneumothorax, both within the last few months. So firstly, do we need to treat any patients with PSP at all? Why do I say that? Because all of you would have seen this excellent paper by Simon Brown and the Australian group, Conservative versus Interventional Treatment in Spontaneous Pneumothorax. What did they do? It was a 1-to-1 randomized study, conservative management versus intervention, but the intervention was quite involved. It was a small bore tube that was left in for at least 4 hours, so not standard thoracentesis or BTS guidance. And their primary outcome was a bit odd in my view, so chest x-ray resolution at 8 weeks, which is not why I treat patients, but nonetheless I understand why they chose it. It was non-inferiority with a margin of 9%. They recruited over a long period, and they demonstrated a clear evidence of non-inferiority. But if you look at the data carefully, there is a bit of a problem. So firstly, that if you look at complete cases only, these were those patients who attended at 8 weeks in order to have their chest x-ray. If you look at those, then there was true non-inferiority with a positive p-value. However, If you assume that the patients who didn't attend were failures, i.e. they had not fully re-expanded, then it fails non-inferiority. Now, according to the authors, a lot of the patients that didn't turn up at the 8th week turned up at the 9th or 10th week with a fully resolved chest x-ray, but I think it's impossible to say whether they were truly resolved at 8 weeks, so there's a bit of uncertainty whether it's truly non-inferior. So is this the end of all interventional treatment for PSP? Well, I would argue strongly that it is not, and here is why. I think there's a problem with the primary outcome, but I think there's also a problem with the applicability of this data to our patients we're seeing every day. Let's just look at their consort diagram. They needed to recruit 316 patients, and to do that they looked at 2,637 patients with pneumothorax. This means that of all patients presenting to them, they only randomized 12% of patients. And that means I think it's not applicable to 88% by definition of patients who you see in the clinic or in the ED. Also, their patients had very low chest pain scores and very low breathlessness. So this was essentially a small number of asymptomatic patients, albeit with large pneumothorax, who they elected to put into this study. And we already knew from the BTS Guidelines 2010 that in some patients with a large pneumothorax and no symptoms, we could leave them alone. I think this study has solidly proven that, but I don't think it's told us what to do with this more symptomatic patients and with that 88% that are not represented in this particular study. And then the second paper, unfortunately, again, is mine. This is the RAMP study Rob Halifax published in The Lancet earlier this year. The purpose of this study was to assess ambulatory management versus BTS-guided management. What does that mean? You all know what BTS-guided management is, aspiration and then a chest tube. Ambulatory management was a single-pass integrated device with a one-way valve which was placed and could be used as a short-term aspiration catheter, or the patient could be sent home with it in situ, and our primary outcome was length of hospital stay to 30 days. What we demonstrated was that the total hospital stay after 30 days, initial hospital stay, initial treatment, all of it favoured the ambulatory device. There was an excess of adverse events in the ambulatory device which were largely related to blockage and necessitating readmission. Of course, that outcome is naturally biased against the ambulatory device because blockage in hospital would not count as a readmission because they were already in hospital. And this is the same presented in a time to event analysis showing that ambulatory care right from day one is superior. Now, if you get out to 20 days, there's hardly any patients and very few patients are still in hospital. So this was clearly a positive study in favour of ambulation and appeared to be safe. Let me apply the same criticism I did to the Brown study to my own study. So is this study applicable? Well, we assessed 776 patients. 192 of these were pushed into an observational cohort. And our patients were very symptomatic. So if you look at how many had chest pain, over 80%, most of them had shortness of breath as well. So in total in this study, from the consort diagram, 1/4 were conservatively managed and 55% of our population were randomized. So I believe that this study is more applicable to the patients that you see every day. So what are our conclusions? Well, conservative management clearly works very well in selected patients, around 12% of your population, and I think that the Brown study shows that definitively, so that's very helpful. But in those who need an intervention, and I would argue that's up to 3/4, ambulatory treatment works. Over 60% can get home on the same day. You do have to have the correct setup in order to be able to ambulate and see them daily, and it is associated with some adverse events. How do I interpret both of these studies? I think in the next 5 years we will see a massive reduction in patients being admitted for chest tubes for PSP. I think it's likely to fade as a treatment for PSP. So thank you very much for your attention. Just as a summary then, I think it's clear that there's been lots of high quality studies in pleural disease over the last year. The parameters that enable future studies are established in development. What do I mean by that? I mean that the outcome measures that we're now using are validated, length of stay, hard outcomes, 100mm VAS, and I think pleural studies going forward are going to have to use these validated outcome measures, and that's for the good of the speciality. And finally, it's very clear that a lot of data we've shown is randomized controlled trials, and this is now mainstream in pleural disease, which is very pleasing for our subspeciality. Thank you very much indeed for your attention.